7, 6, 5, 4, 3, 2, 1.
Howdy, CROC Nation. Dr. Tommy and Ellie here with you with another amazing CROC podcast. Amazing, not because of me, not because of Angel. Well, a little bit because of Angel, but mostly because of you guys, the greatest and most courageous people in the world, our cancer survivors / thrivers. Welcome to another CROC podcast. Angel Santana, have faith, let it begin. How are you doing, my friend? It's been a couple of weeks.
We're hanging out on the eve of Father Donor Dance. I had a great time. I've had a great weekend, but I missed you.
Yeah, I miss you too. And I'm glad we're back. I took a little vacation. We had that 3-episode Len Berry marathon, which was so wonderful and so enlightening. And I hope that our listeners enjoyed the fruit of that amazing podcast series. And we're going to go in a little bit of a different direction tonight and kind of get back on track with our usual agenda. And tonight's agenda is very interesting and very, very important to me, very dear to my heart. And it's the process of trying to figure out how to give a survivor thriver bad news. Now, in cancer, what people always tell me is that my day must be 100% about relaying bad news or dealing with death and dying. And it's anything but that. You know, cancer is a disease like any other disease, no better, no worse. And there are many, many stories of survival and cure. As a matter of fact, most of our patients are cured of their cancer, and they just have a different name of a disease, which just conjures up more fright and more fear and more terror. And that's why we do this podcast. But on those occasions, when bad news does need to be disseminated, I notice even in my own career that we as physicians and advanced care practitioners and caregivers of the wonderful survivor thrivers don't do a terrific job disseminating these types of, or being good at these types of conversations. So there was an instance that happened to me a few weeks ago that I wanted to talk about, and it's not so much a confessions podcast because I did everything exactly the way I should have. However, I probably could have done a better job. And it's about a man, I'm going to call him Douglas. And Douglas, honestly, was one of the sweetest, gentlest souls that I've taken care of in my 35 years as an oncologist. Just the sweetest man. I just can't say enough good things about him. And of course, as sweet as he was, his cancer was devastating and extraordinarily aggressive and catastrophic. I'll even use that word. And we really did a great job helping him and really made things better for him. It didn't change the outcome. And when things started to fall apart, I think that the concept of telling bad news could have been done better, and it could have saved everybody a great deal of pain, including the patient and his family, and including me and my staff, because we weren't on the same page. So I was really motivated by Douglas, and I want to dedicate this podcast to his memory. What a fine man he was. So people who have cancer, we call them survivors, we call them thrivers. They want and deserve to be given information about their cancer truthfully and objectively. We as caregivers and providers are very uncomfortable doing this and being transparent about some things that are just very hard to talk about, like death and dying and having a type of cancer that may not be amenable to cure, or having a cancer that has come back, or a cancer that has progressed, or a cancer that has metastasized. And it puts us in a very uncomfortable position. Because of this, I think that's the root of why we do such a bad job. But in this podcast, we are going to try to teach the doctors and the nurses and the advanced care practitioners how to have these conversations with finesse, with empathy, and with respect. And I'm going to quote a paper, which is really the Sentinel paper, about how to do this. And it's called the 6-step program, a 6-step protocol for delivering bad news. This is such a great paper. This is such a landmark paper that it was written in the year 2000. In case you guys are keeping score, it's currently 2024. So this article was written 24 years ago and is still the most quoted article on helping physicians and advanced care practitioners deliver bad news and how to have those difficult conversations. The primary author is Walter Bailey. He's from the MD Anderson Cancer Center, probably the best cancer center in the world. And some of the co-authors were from Toronto. So I want to give an understandable and deserved shout out to them. So Angel, just to put a little background to this, being a physician in the 1950s to the 1970s, the thought process, according to questionnaires and different, qualitative papers that were written about this, the attitude of the physicians was that giving bad news was inhumane and damaging to the patients. And as a result of this feeling, bad news was never discussed. A patient was never told their prognosis. They were never told their stage, were never told what to expect, because it was hidden from them. And just to make sure that we categorize this properly, what are examples of bad news in the oncology world? We sort of touched on this. Recurrence of cancer, progression of your cancer spreading to other areas called metastasis, failure of treatment, irreversible side effects from their treatment, bad genetic testing, meaning a person has bad genes that might portend to a future cancer or for their children, and the discussions that go around hospice and advanced care directives like DNR and intubation and things like that. So that's basically what we're talking about. But breaking bad news is a complex communication task. It's not just about the verbal part, Angel. It's not just sitting down with a patient and telling them the bad news. That's only one component. It's really responding to the patient's emotions, whatever those emotions might be, managing the family of the survivor thriver, managing the expectations, which are in upheaval, because most of the time the doctors and nurses and nurse practitioners and PAs are basically being cheerleaders and being optimistic, and me being the number one cheerleader about that, practicing optimistic medicine. And then all of a sudden that optimism turns sour. So of course the expectations, are basically blown up. And figuring out a way to communicate this information and giving hope even when the situation is bleak. That's going to be really what we're going to be focusing on and what we're hoping to be able to teach our colleagues. So according to the studies, Angel, 85 to 91% of patients want the truth. The idea that receiving unfavorable medical information will cause psychological harm is unsubstantiated. It's just not true. Number two, it's the ethical and legal thing to do nowadays. Patients have rights. Patients have rights to what's called an informed consent. Patients have rights to know what their prognosis is. Patients have rights to know what's going on in their care. In addition, copping out, the physicians copping out and not telling the patient the truth may actually subject that patient to unnecessary treatment. So if we know that the patient's not responding and they have an incurable disease or an incurable type of cancer that pretty much there's nothing left that we have to do, and if we don't have that conversation, then the patient can't really make that decision to stop treatment and then go for quality of life, go to palliative care, and then go to hospice. They're just going to continue to reach and try to grab and just claw for whatever treatments might still be out there, whatever experimental treatments or whatever. We call that the mum effect, and I think that's pretty cute. Like mum is the word, reluctance to deliver bad news. And the goal tonight, Angel, is to be honest with our patients without destroying hope. And without further ado, let's hit the paper. But before I do, let me see if you have any thoughts on that.
Well, I'm over here watching my son and you can hear him screaming right now. But that's what I was going to ask you, believe it or not. Believe it or not, his scream actually made me want to ask you this question. So if you want to wait to answer it, let me know. How is it that as a physician, when you are taught to deliver bad news, when were you taught this? And then when you executed it, I would presume it's like anything, just nothing what you're taught and what you have to do are one and the same.
That's an excellent question, and I have a really, really sad answer to that question. We are not given those skills. We are not taught those skills. There is nothing, at least in my day, and I doubt even in the modern age, does anybody actually even, give any priority to teaching young physicians and young medical students this skill. So thank you for that question. It's an amazing question, and I'm really actually embarrassed to say that we really don't do a good job. This paper was published in the year 2000. I just read it for the first time, this week to prepare for the podcast. I didn't even know it existed, to be honest with you.
Wow. Okay. That's really my only question right now.
Oh, no, it was a beautiful question. Thank you. And it really brought up something very important. So let's go through the 6 steps, Angel. The first step, and I think each of these 6 steps we've touched on in different podcasts, but let's start with the S for Spike. So setting up the interview. So when you preach, Angel, at the church and, the pastor needs a day off to go fishing or is ill and you are asked to pinch hit, you don't just like go up to the pulpit and just wing it. You have to prepare, for whatever lesson or whatever story that you're going to tell or whatever, Bible verse that you're going to be teaching on. And I think the same is with these types of conversations, these uncomfortable conversations. I think you have to do what's called a mental rehearsal, and you need to be prepared. And I know that I set up my charts in the morning, I go through everything. And when I have the time to do that, it makes my day so much better. And the experience for the patients are so much better because there's preparation. Even more so for these types of conversations that are going to be remembered forever between the family members. How the doctor, nurse practitioner, PA, how they handled themselves and how they handled the situation. So rehearsal is important. In addition, we have to make sure that we are ready and prepared for the possibility, the very, very great possibility that negative feelings and emotions and frustrations will be thrust upon us, thus making it so stressful and uncomfortable for us as healers to step out of the role of being a healer to be a failure or at least a perceived failure. So expect these types of emotions. And I think the first place to start, and I really like the way they set this up, is actually trying to make an environment that's conducive, undistracted. You don't want to be distracted and you want to be focused for this type of conversation. You don't want your cell phone going off. You don't want people interrupting you. You want to be in a room. You want to make sure the room is private. Now, I'm very lucky because I'm in an outpatient center in the cancer center. We have a beautiful department. We have a bunch of consultation rooms and exam rooms and my office and different spaces where we can go and be alone. It's harder for a hospitalist or a hospital-based physician, especially in the emergency room when all they have is these little thin curtains that separate people or even on some of the floors where there's double rooms and there's really not much privacy. But you need to make sure you try to arrange for some privacy. And then you have to involve the patient, the survivor, thriver, their family, and you want to make sure they're part of this. You also want to be at eye level with the person. So if the patient is sitting down, you should be sitting down. You should be looking at them in the eye. You should not be rushing. You should be taking your time and try not to have any barriers between you and the patient. We talked about the computer and the monitors. Like that is absolutely taboo. Do not look at the computer, look at your patient. Then make a connection with them, make an empathetic connection, with your body language, your eye contact, just, being accessible, being close enough to be able to hold their hand or to stroke their arm or whatever, be available to them emotionally. And then also manage your time. I mean, this is not one of those things where you have a patient coming in for a follow-up. You say, hey, Joey, everything's great. PSA is 0. You got no cancer. You're doing great. I'll see you in 6 months. This is something you sit down and it doesn't really matter how long it takes. It'll take as long as it has to take, because each of these conversations have their own life. The P, so we went spike, S. Now the P is for patient perception. So I actually am good at this, because a lot of my colleagues who send patients to me fail to tell the patients exactly why they're coming to see me. So the first thing I'm going to say is an open-ended question. So what has your doctor told you about your situation? Do you know why your doctor sent you to see me? Do you have an idea of, some of the things that happen here in our department in radiation therapy? And I think when you ask these open-ended questions, you get a lot of insight. And one of the good things we were trained in medical school and in residency is to be able to size up a situation very quickly. So you can find out probably within 20 seconds what the capacity is of your patient, what they understand, what their comprehension level is, where you need to be, because you have to be at their level. You can't expect them to jump up to your level. You have to basically go to their level. And, so when you talk about them, what have you been told about your medical situation? What is your understanding of the reasons why we did this test? You can tailor the bad news to how the patient understands and to their level of understanding. And you can also, it's really important during this step, this perception step, is to find out where they are also on the emotional side, in the sense that, is this a patient that is basically in denial, which would be an extraordinarily understandable response to something as stressful as cancer? Are they in a wishful thinking mode? Are they omitting essential unfavorable information and just forgetting it, just trying to get it out of their minds? The medical details, are they realistic or unrealistic about their expectations of their treatment? So these are all the things that we want to find out during that perception phase. The I, obtaining the patient's invitation. And this is what happened with Douglas. And it really wasn't anyone's fault. It just was what it was, is what it is. The majority of patients desire full disclosure. They desire full information, and some patients don't. Douglas did not want to know the details of what was going on, and I respected his wishes. But I could have done a better job, I think, being able to maybe contact the family or speak to his family if given permission, because when things went south, his family did not take it well. And I think that was one of the things. When we get to empathy, we're going to talk about that. Also, shunning information, is a valid psychological coping mechanism. So I'm not putting down any survivor thriver who really doesn't want to know anything too much in detail. I respect that, but we have to make sure we know who we're dealing with. Also, you should ask your patient, how would you like me to give you the information about the test results? Would you like me to give you all the information, or would you like us to sketch it out, sketch the results, and spend more time discussing the treatment plan? And offer to answer any questions if they don't want to talk about it at that moment, or if they're psychologically just not capable of being able to have this conversation at this particular time. Make sure you're available to be there when they are ready. The K, giving knowledge and information to the patient. A lot of people feel that they want to warn the patient. They feel that giving them a little bit of a heads up before you go right into the bad news may lessen the shock. So you start out with, hey, Joe, how are you? Unfortunately, I've got some bad news to tell you, or I'm sorry to tell you X, Y, and Z. I think that given the facts and given it sort of makes the patient sort of absorb the initial shock and sort of roll with it with you. You also, again, back to the perception, you have to start your conversation with a level of comprehension of vocabulary that will fit the patient. So you do not want to use fancy words. You don't want to use the word metastasized. You might want to say your cancer has spread. You don't have to say we need another biopsy. You can say we need to sample some tissue. You also want to avoid being too blunt. One of the things that I have to work on is sometimes my bluntness. So it's a problem. And when you're giving bad news, you don't want to be blunt. You want to be super, super empathetic, and you want to be unrushed, and you want to be just there and present for the patient. You also don't want to say anything stupid, like you have very bad cancer, and unless you get treatment, you're going to die. Remember the famous story of the woman with the bone scan that lit up like a Christmas tree, because patients will feel isolated and they'll feel angry and they'll blame the messenger of the bad news. And that certainly, I've learned that lesson many times. You also want to give the patient information in small chunks. You don't want to give them too much at one time. You just want to take your time and give small little bits of information, answer questions, and then move on to further information rather than having to, remember, you're not giving a lecture. You're not a professor giving a lecture to a class. You're there to have a conversation, a shared conversation with your patient. You also want to avoid using phrases like, there's nothing more we can do for you. That's actually not true. We may not have any more therapeutics, but there's a lot of things we can still do to help our patients. Step 5, the E, the emotions with empathetic response. We're going to spend a little bit of extra time on this because this is where the money is, right? So this is where we really need to really dig in. So responding to a patient's emotion is the most difficult challenge of breaking bad news. And this is where we have trouble. This is why we get stressed when we have to have these conversations. This is why we're so uncomfortable, because inevitably, there's the potential that the patient could be angry at you, could get mad at you, can yell at you, can start crying uncontrollably, can be absolutely, the scientific word, lose their shit right in front of you. And you're going to feel extraordinarily impotent. You're going to feel like, there's not, you failed. Like, this is a two-way conversation. We can do a whole podcast just on the practitioner's feelings and how they have to cope with having to give this types of news because you've been with them the whole way. You've been with them with the diagnosis. You've been with them during the first set of treatments. You've been with them when they went into remission or when they went into what we thought was going to be a cure. And now all of a sudden you have to go into a new role and you have to almost take back everything that you've said to them in the past. So there's this patient expectation. We have a fear of destroying the patient's hope. We fear our own inadequacies that we have to have these conversations because they failed on our watch. And you have to make sure that we don't feel that we're unprepared to manage these patients' anticipated emotional reactions. And we also feel embarrassed, Angel. There's an embarrassment that we painted too optimistic a picture. And I think with Douglas, this was the thing that hurt me the most, was that when he did so well, even though in the global sense, we knew it wasn't going to be forever, but he really far exceeded expectations to the point where I actually took photos of the response that he's had and gave lectures, inserted these photos in lectures to the medical students and the interns about what a great job we did. And I was, I guess, bragging about what a great job we did. And then, a couple of months later, when the cancer came back, it was like, wait, I thought I was doing really good, or I thought, what you were just telling me how great I was doing, and now I'm not doing great anymore. And that really is where the struggle lies with us having these conversations. So let's talk a little bit about the 4 steps of empathy and how we need to empathize. So first, we have to observe our patients for the emotion. So we have to look at any tearfulness, sadness, silence, shock. Then we have to identify that emotion that's being experienced by the patient, and we have to name it. And only after the ability to do that, once we get to that part, we can then identify the reason for that emotion. So the reason is usually because of the bad news. In the case of Douglas, it was because he got angry because all of a sudden he thought he was doing great, and then all of a sudden he's not doing great. There's a confusion, and that's where that emotion came from. So at that point, number 4, I give Douglas that room, give him that space, give him that safety to be able to express their feelings. And then from there, you reply in an empathetic way. I'm sorry to say that the x-ray shows that the radiation didn't do well, or I'm so sorry that the treatments did not give you a durable response. I can understand why you feel frustrated and angry that this came back when you were doing so well, and how confusing that must have been for you to now have to deal with this news after thinking that this was all behind you. So it's these dialogues to be able to not get too wrapped up in being the bad boy or the bad girl or being the bad doctor or being, the incompetent practitioner that failed your patient. It's not that you failed your patient, it's that the cancer, you know, performed in the way that cancer was going to perform, and it was despite our best efforts. And I think that that's really the key to empathy. And it's at that point, Angel, where you offer your patient a tissue, or you take them by the hand if you feel comfortable, or hold their arm and just try to support them both emotionally and physically. And one of the harder parts is when a patient doesn't express any emotion or they're silent. Then you have to be exploratory with your questions, ask a few questions. Before you could become empathetic, you want to know kind of what they're thinking. We've all had, very awkward conversations with people, whether in business or private or in personal relationships, where you don't know what the other person is thinking. So it puts you at a great disadvantage. So you have to kind of figure out, utilizing some exploratory questions about where they are emotionally. So then you can go into the 4 phases of empathy. And you want to make sure, because what we never can forget is that the patients regard us, they regard the oncologist as one of their most important sources of psychological support. And when you're able to combine empathetic, exploratory, and validating statements, that's the most powerful way that you can offer support to the patient. And it reduces the patient's isolation, it expresses solidarity, and it validates the patient's feelings or thoughts as normal and as to be expected. And there are some examples of some of these validating responses and empathetic statements that you can use in paper. It's so wonderfully written. I can see how upsetting this is to you. I can tell you weren't expecting to hear this. I know this is not good news for you. I'm sorry to have to tell you this. I was also hoping for a better result. And then putting it all together, again, planning the discussion in advance, creating a comfortable setting, encouraging family friends to be present, assessing the patient's ability to discuss bad news, confirming the patient's understanding of their cancer, assessing how much the patient wants to know, organizing a strategy for disclosing this information, including family and caregivers in the discussion, providing information in small increments, avoiding medical jargon, checking to see if the information was correctly received by the patient, reinforcing and clarifying information, detecting anxiety, detecting sadness, handle the patient's emotional reactions, and responding empathetically. And at the end of the day, Angel, I think that this is something that we do multiple times a day, many, many times a week, hundreds and hundreds of times in a year, and thousands of times in a career. But how many times are we really doing it properly? So hats off to these people who wrote this paper 20 years ago. I got the information a little bit later than I wish I would have, but I have it now and I'm going to use it. Angel, your thoughts?
Famous comedian Tracy Morgan once said, "Bad news travels at the speed of light, and good news travels like molasses."
Yeah.
I think that what we've noticed here is you humbling yourself and allowing yourself the opportunity to show others that there is a work in progress. There is a method, and there is a way that you can, not perfectly, but carefully calculated, deliver a message, especially the one you don't want to deliver in a timely fashion.
Angel Santana, always the wise words. Thank you, my friend. I want to just reach out and just have a quick word, my quick pep talk to our Survivor Thrivers. There is going to be a day when all of us have to be sitting in that chair and have to receive that bad news. It is our prayer here at the CROC organization, Angel, myself, the board of directors, that you have a doctor, that you have a nurse, that you have an advanced care practitioner who really is very good at giving bad news, that knows these 6 steps, that is able to keep you in a safe place and help you get through that bad news. Because believe it or not, as hard as that bad news is going to be to hear, it's going to be really important that you do hear it and that you do digest it and metabolize it. So then you could participate in the plan moving forward on how to proceed, whether that be through palliative care, whether that be through hospice, whatever that process is, bringing family members together, taking care of your last minute agenda things that you need to do to close all your loops. These conversations are not pretty, they're not happy, but they're necessary. And I just pray on behalf of everyone here at CROC that you have people having these conversations with you that are experienced and empathetic. To the board of directors, thank you so much for always your input and always for your support and your sharing of your talents for our amazing Survivor Thrivers. And I'd like to end this podcast as I end all podcasts with a blessing and a prayer, wishing each and every one of our Survivor Thrivers a long, healthy, happy, and cancer-free life. God bless you. God be with you. Peace.